Hello everyone, welcome back. Today we are going to see about another important aspect in perio, which is nothing but mucogingival surgery. Okay, so as the name implies, mucogingival, something which is involving the mucogingival junction, the alveolar mucosa, and the gingiva. Right. So the combination of these is going to be called as mucogingival surgery. So mucogingival surgery has now been replaced by the term called perioplastic surgery. Okay, mucogingival surgeries are now being replaced by the term called perioplastic surgery because they found out that some procedures are involved in aesthetics for the aesthetic enhancement. So it just not only involved in gingiva, but also it is involved in aesthetics, soft tissue aesthetics, hard tissue aesthetics. So that becomes perioplastic surgery. Okay, so we are going to deal only about the soft tissue in this perioplastic surgery, and we are not going to talk about the hard tissues. Okay, so before moving into the mucogingival surgeries, okay, we are going to see about a lot of terminologies which I'll be using throughout this lecture. Okay, so I'll just having a quick recap of various terminologies which I'll be using throughout the lecture. So the first one is width of attached gingiva. First chapter, basics, gingiva. For width of attached gingiva. So attached gingiva basically is a firm resilient structure which is tightly bound to the underlying periosteum of the alveolar bone. Okay, so the attached gingiva is a firm structure which is bound or which is attached to the periosteum of the alveolar bone. Okay, so I'm going to measure how much amount of gingiva is actually attached to the bone. That is what I'm going to call that as width of attached gingiva. Okay, that is what I'm going to call it as width of attached gingiva. So width of attached gingiva is nothing but the distance from the gingival margin to the mucogingival junction minus the probing depth. The gingival margin to the mucogingival junction, and I'm subtracting it with probing depth. That will give me the width of attached gingiva. Okay, so normally the width of attached gingiva for upper anterior should be 3.5 to 4.5 mm. For upper premolars and posteriors, it's going to be 1.9 mm. For lower anteriors, it should be 3.3 to 3.9 mm, and for lower premolars, it will be around 1.8 mm. Okay, so this is how we are going to talk about width of attached gingiva. So whenever I say this procedure require adequate width of attached gingiva, what do you mean by width of keratinized gingiva? Very simple. The distance from the gingival margin to the mucogingival junction, the entire gingival margin to the mucogingival junction is called as width of keratinized gingiva. So if I say that this procedure require adequate width of keratinized gingiva, or this procedure increases the width of keratinized gingiva, it means it increases the entire gingiva from the gingival margin to the mucogingival junction. Fine. Next, moving on to gingival recession. What is gingival recession? Gingival recession is the apical migration of the marginal gingiva, apical migration of marginal gingiva below the level of CEJ. That is a very important word, because any migration of the marginal gingiva below the level of CEJ, that is going to called as gingival recession. Okay, we'll be talking about what are the causes of gingival recession, what are the classification of gingival recession, how we are going to treat gingival recession. That is the whole concept of perioplastic, right? Very good. Now coming to graft. What is a graft? Graft is a piece of tissue which is taken and placed to supply a defect or a deficiency. Okay, that piece of tissue which is taken and placed to repair a defect or a deficiency can be taken from the same individual, autograft, or from a different individual, xenograft. Okay, so it can be taken from the same individual, the same species, allograft, or from a different species, xenograft. Okay, so graft is a piece of tissue which is taken and placed to supply a defect or a deficiency. Okay, very good. Now, what is a free graft and what is a pedicle graft? Very simple. If a stem or tube of tissue, see the definition might look difficult, but hang on. Okay, a stem or a tube of tissue which remains attached to the donor site is called as pedicle graft. What do you mean by this, sir? It's very confusing, or it is very difficult. See, if I am not cutting the entire gingiva, I am just displacing the gingiva either laterally or coronally, or I am rotating the flap, which means the flap is just being pulled, it is not detached completely. That is what a stem or a tube of tissue remains attached to the donor site. That is what is called as a pedicle graft. So a piece of tissue will be attached to its original site, right? Say for example, I'm completely taking the tissue and placing it somewhere and suturing. That becomes a free graft. Can you tell me the example of a free graft? Excellent. Connective tissue graft, free gingival graft. All these we will see, okay? Don't get confused. So connective tissue graft or free gingival graft, which is taken from the palate. So from the palate, I will just cut the piece of tissue. I'll completely remove that piece of tissue and I'll place it wherever I need it. That becomes a free graft. Whereas I'm not going to completely detached, I'm just going to move to the adjacent or lateral sites. That becomes a pedicle graft. So pedicle graft is a stem or a tube of tissue that remains attached to the donor site. Fine, very good. So now coming to frenum. What is a frenum? A frenum is nothing but it is a bundle or a cluster of muscle fibers. Okay, it helps to attach the alveolar mucosa cheeks to the gingiva and the bone. It is a fold of mucous membrane which predominantly has muscle fiber in it. Okay, it can predominantly consist of muscle fibers. So what is the function of a frenum? A frenum is the one that helps to attach the alveolar mucosa cheeks to the gingiva and the periosteum. Fine, very good. What do you mean by plastic? To give shape to any substance, that is plastic. Okay, to give any shape. What is aesthetic and cosmetic? Aesthetic is long term, cosmetic is short, quick, good appearance. If I want a long term result, that becomes aesthetic, long term. Short term, cosmetic, quick, short, good appearance, cosmetic. Root biomodification and smear layer. What is root biomodification? Very simple. First, you should know what is a smear layer. Okay, this is in periosmear layer, not endo. Okay, so smear layer is nothing but it is a combination of plaque plus calculus plus contaminated cementum. So the combination of a plaque, calculus, and a contaminated cementum which is present in the root surfaces combinedly called as smear layer. So whenever I'm going to do any kind of mucogingival surgeries, I should make sure that the root surface is clean, it is free of smear layer. So to remove a smear layer, I will add some agents to remove the smear layer. Okay, those agents are called as root biomodification agents. those agents are called as root biomodification agents. So some root biomodification agents are citric acid, okay, or tetracycline. Citric acid has a pH of 1. It is kept in place for 3 minutes. Tetracycline of about 50 to 125 mg per liter is kept in place for around, say, 3 to 5 minutes. So all these agents, the root biomodification agents, they are going to remove the smear layer, which is nothing but block calculus and contaminated cementum. Why a smear layer needs to be removed? Because whenever I'm planning to place a tissue or do mucosal surgeries, I should make sure it is clean, smooth surface. Okay, very good. Now, finally, what is creeping attachment? Creeping attachment is nothing but it is a post-operative coronal migration of gingival margin. So in some patients, we would have seen that there would have been mild gingival recession. Say for example, a 20-year-old boy reports to the clinic with mild class 1 gingival recession in the lower anterior, say for example 3-1, and you just did a general scaling, and the next week he comes, it's perfectly normal. That is because of you eliminating the etiological factor plaque, plus if you have identified the proper etiology, say for example if it would have been faulty tooth brushing, then if you would have corrected that faulty tooth brushing, plus you did scaling, then the combined results, there is going to be good movement, upward movement, coronal movement of the gingiva. That is called as creeping attachment. So creeping attachment is the coronal migration of gingival margin post-operatively. Fine, this is called as creeping attachment. Now we have looked about a various terminologies. So before moving into this mucosal surgery or the perioplastic surgery, we are going to look about a lot of terminologies, right? So first one will be the attached gingiva, gingival recession, graft, free graft, pedicle graft, frenum. What do you mean by plastic, aesthetic, cosmetic, root biomodifications, smear layer, and creeping attachment? Okay, so once you get familiarized with all these terms, whatever terminology I'm going to speak inside will be a very easy thing or a cakewalk. Pedicle graft, some piece of tissue remains attached to the donor side. I am not completely cutting the tissue and placing it. If I cut the tissue completely and place it in the other side, that becomes free graft. Fine, very good. Now moving on to the objectives of perioplastic surgery, very important. Okay, so why we need to do this? Objectives of perioplastic surgery is, one is to remove the muscle pull, frenum, to deepen the vestibule, to correct any bone defects, to cover the denuded root surface. Okay, so these are all the few objectives of perioplastic surgery. That is, I'm going to increase the size of the vestibule, or I'm going to do a frenectomy or a crown lengthening, or to cover the denuded root surfaces. Okay, so we are going to see the first four important procedure. What we are going to see is to cover the denuded root surfaces, the root coverage procedures. Okay, so the first and foremost thing what we are going to see now is the root coverage procedures. Okay, fine.